So, the focus today, as requested, is going to be synostosis. We also have to go over a couple of more benign entities quickly in order to know how to define synostosis from benign craniofacial disorders that don't require surgical intervention. And then we'll review, after we sort out how to diagnose craniofacial disorders, the tools that we have to treat them, and how those are evolving, and then some of the evolving research opportunities, in terms of where the field is going. So I have no conflicts of interest to disclose. So the first thing that's important and fun about craniofacial is that it's a team approach. I think it's always important for you guys to understand what some of these subdisciplines mean in terms of practice, and the way in which these entities are structured. So the treatment of craniofacial disorders is a collaboration between a neurosurgeon, typically a pediatric neurosurgeon, and a pediatric plastic craniofacial surgeon. So both of those entities require a fair amount of sub-training, even within a subdiscipline. So craniofacial disorders, being predominantly pediatric, require therefore that you are, so on the neurosurgical side, beyond neurosurgical training, pediatric neurosurgically trained, and then beyond that, craniofacial pediatric neurosurgical training. So it's something that really requires you to target an institution that carries that subspecialization in training for your fellowship, in order for you to come out appropriately trained to do this. Or in some cases, it requires an additional year. I was lucky, I did my fellowship at Sick Kids in Toronto, and that is an institution, and I just heard you're gonna have Dr. Brutka be sharing with you soon. He's just an unbelievable, he's one of my phenomenal mentors. And I was very lucky to train there, and a huge volume of what they do is craniofacial surgery, which is where I gained my training in this. And plastic surgery, similarly, it goes well beyond, so they have to be trained in plastic surgery, then pediatric surgery, then craniofacial surgery. So not every plastic surgeon is a craniofacial surgeon or has that background or training. And so the team that ultimately comes together to perform the procedures that I'm about to go through is fairly specialized. And therefore we have a multidisciplinary center that treats these patients. We'll go over why when we talk about the types of syndromes that these patients can have. And so therefore we then have a coordinator dedicated just for these patients. So that's Michelle Buontempo, that other individual that you're seeing there. So, it's just important to understand that this is a multidisciplinary set of disorders. This is something that requires a team-based approach. And, just important to understand the steps that need to be taken to get from point A to point B if this is something that you're interested in. So we'll start first with just getting, everyone involved a little bit here, and then we'll get into the nitty gritty. So in terms of craniofacial disorders, everything really comes down to understanding how to interpret what you're seeing in terms of a child's calvarial or skull and facial morphology, the way they look. And so really the majority, as you'll see as I go through how to diagnose these disorders, the majority of this skill is all in physical diagnosis. It's in physical exam, which is what makes it really interesting and engaging. So yes, we can use scans, typically CTs, not really X-rays or MRIs, because we're looking at bone anatomy and whether or not the bone structure is normal or abnormal. So typically we're using CT, and that's not really something you want to use a lot in the infant population because of the exposure to ionizing radiation. And so really, it's a nice art because there's huge reliance on physical exam still. So important to understand the terms we're using, what they mean in terms of how we're describing a patient's head shape, and then how that starts to key us in on what might be going on. So I'm trying to think of how to do this best since I can't see you guys and you can't talk to me. Can I see your chat questions? So I'm trying to look at the bottom to see if I can.
We should be able to, yeah.
I know, and I can't see the bottom. Let's see. Because I'd like you guys to be able to answer these for me. Or if you can see them, then you can let me know what people are saying.
Yeah, I can do that.
So, all right. What is this entity of the selections on the left? Which one of these is this? Do we have any answers or any takers? Radio silence.
Yeah, not yet.
Okay, no, it's good. It's good. It gives me a sense as to how much we need to go over. And
Someone says brachycephaly.
excellent, brachycephaly. So this is symmetric flattening of the back of the head, or brachycephaly. So as we go through how to diagnose different synostoses, this will key us in on either a form of benign plagiocephaly or coronal synostosis, and we'll go over that. All right. What is this one? Somebody knows. If you know brachycephaly, you know this. Nothing. This is scaphocephaly, okay? And so we'll go over the details, but scaphocephaly, elongated boat-shaped head. That's why it's called scaphos. All right. Anyone? What is this?
Oh, trigonocephaly, someone said?
Yeah, trigonocephaly. Excellent. Ooh, and now I can see you, John Raquel. Okay, good. All right. So yes, trigonocephaly, indicative of metopic synostosis, which we'll go over. Okay. What's this one? Nothing. Yes, excellent. That's a tough one. And we'll go over why. That was plagiocephaly, and then I clicked one too quickly because I was trying to get the chat back up. And then lastly, what's this one? Ignore that. Sorry, when I clicked to try, there we go. Nothing? Something? Nothing. This one's tricky. So this is anterior plagiocephaly or coronal synostosis. All right, so we'll go over that. And then lastly, this is turicephaly, turibrachycephaly, syndromic synostosis. All right, so how do we figure all this out? So first, let's start with the simple stuff to get it out of the way and understand benign versus surgically pathologic. So a 2-month-old baby presents to your clinic for a routine well baby visit. They were born via term vaginal delivery, no complications. The child is gaining weight well. Parents are concerned about the head shape. They describe that this child has a difficulty turning their head to the left since birth, which you would note as torticollis, and you notice an associated right-sided occipital flattening with anterior displacement of the affected ear and forehead bossing. This is what this child looks like. So displacement on the right side, flattening on the right, ear pushed forward, forehead pushed forward. So this is what this would look like if we represented this schematically. Again, flatness along the back of the head, the anterior displacement of the ear called dystocia, and anterior displacement of the forehead. So this is plagiocephaly. So this is the only benign entity. Everything else we're going to talk about today is surgical. This is plagiocephaly, okay? So the cranial asymmetry is secondary only to forces that deform the skull from external to internal. So different from synostosis, which we'll go over, which is clearly an internal to external result of pathologic skull shape. This is simply from children having a preference, being put to sleep on their backs, or having true torticollis, meaning they physically can't turn their head well in one direction. There are a lot of other factors, meaning you always want to ask a mother if they are breastfeeding, and if they are breastfeeding on one side or the other exclusively, because your forearm is hard. And so if you have differences in production, you have to learn how to ask these questions. They'll say, oh yeah, I have differential production. I'm only ever feeding my kiddo on the right. Well, the left side of the head's going to get really flat because it's resting on the mom's forearm all day. Or are they being bottle fed exclusively? That's another issue. If somebody's a righty or a lefty and they're only getting bottles, they're not shifting back and forth. So, there are all these little tricks that you start to learn, but the bottom line is this is not surgical. This is benign. This gets better on its own. It started to really crop up since the Safe to Sleep campaign, meaning every child is put to sleep on their back since 1994 to decrease the incidence of SIDS. You see the characteristic morphology that we just went over, meaning there's asymmetric flattening of the occiput. There's a characteristic lack of ridging. There's a lack of compensation, which we'll go over what that means, and longitudinal improvement, meaning usually this starts to get better over time. You ask the parents if it's getting better or worse, and they say, no, we noticed some flattening. It's getting better. The treatment for this is just behavior modification. You get these kids on their bellies, aggressive tummy time, physical therapy for the torticollis, plus or minus helmet therapy. I'm very against helmeting. I think it just doesn't have a role. We've found over the last 10 years that children get better on their own exactly the same as what helmet therapy would accomplish, so I tend to stay away from it. You do not need imaging. This is physical exam only, and children get better with time, physical therapy, and behavior modifications. By age 2, you usually see this decrease substantially to a point prevalence of only about 3 years. And when you look at teenagers, only about 2% of the population feels that they have any residual flattening. All right, so that gets the benign out of the way. Again, helmet therapy not needed. So let's move into the surgical entities and those that we treat as a surgical team. So let's review the sutural anatomy first, because this is what we'll be dealing with for the rest of the talk. So the infant's skull is simply a composite of big tectonic plates. They're not fused because you need to allow for delivery, in which through typically, if it's going to be a vaginal delivery, the overriding of those bone plates so that the calvarium can get through the birth canal. And then once delivered, you need to allow for brain growth. So the skull cannot be static during early infancy and into 2 to 4 years of age, so that you can allow for brain growth and all of these rapid changes that are occurring. So nature's solution for that was sutures, which are natural openings in these bones that allow for growth, and they also allow for overriding. So we see those represented here. They are sites of dynamic bone deposition and resorption. Alternatively, as the skull grows, they allow for adjustments in size and shape over time, and they are viewed as these little spiculated bony projections with these irregular edges over the pericranium. What happens is there is stretching of those sutural ligaments between the sutures as the child's head grows, and that stretching indicates through chemical gradients and chemical mediators to keep those sutures open. It states, nope, the brain is growing. We need these open. Keep these open. Do not lay down bone yet until they start to lessen, those signals lessen and lessen and lessen as the child's head stops growing as actively, and therefore then the signals shift to, okay, we can now shift from bone resorption to bone deposition along those ridges, along those sutures, and then you end up with a fused skull somewhere around the age of 4 to 5. So looking at how quickly these close, so in terms of the anatomy, number 2 here, that forehead suture is the metopic suture. Can you see my arrow? Okay. Looking at number 4 here in the sagittal view, that's the coronal suture, and you have paired coronal sutures on either side. Moving back here to the lambdoid suture, number 18, and looking from a bird's eye view, number 29 is the sagittal suture. Those are the most commonly important. There are a lot of other ones that you see here. For myself as a craniofacial surgeon, they're actually all important because of the midface fusions that develop in syndromic children. But for this purposes of this talk, we're going to stick to the larger, more significant ones. So these sutures close at different times throughout an infant's life. The metopic closes first, and it can close as early as 2 months. Typically, it will start closing at 4 months, then the sagittal suture, then the coronals, and then the lambdoids. The squamosal is this little one down here. It's not that important clinically. So it's important to know these numbers because children will come in as in referral all the time for assessment of ridges. And you have to be able to figure out the difference between a normal ridge just because of active bone deposition versus a pathologic ridge that represents synostosis or early fusion. So the metopic, being the earliest to close, always will start robustly ridging about 4 months of age. It causes common concern. I assess hundreds of these kids every month for ridging that is not fusion. And we'll talk about how we know why. So what is craniosynostosis? So it's the ossification of one of these calvarial sutures before the functional need for adaptation of the skull is complete. So an infant could have closure of all of their sutures at 4 or 5 months of age if they don't need head growth. Why would that happen? There are children that have ischemic insults during delivery, hypoxic ischemic encephalopathy, perinatal strokes, migrational disorders. These children, and those are all separate talks in of themselves, but those children are not going to have normal brain growth. And so they're not going to receive the signals stretching the fibrous ligaments between the bone plates, telling those sutures to stay open. and they'll close them, but that's perfectly appropriate because that child actually doesn't need room. It doesn't need a larger skull because their brain is not going to grow to a normal capacity. So again, that child wouldn't have a functional need. So if they close at 4 months of age, that's actually normal for that child. So you have to understand and be very aware of the overarching global picture of these children in order to diagnose them appropriately and to avoid intervening inappropriately, right? So I see this often, second, third referrals, second, third opinions, et cetera, for a prematurely closed suture. You have to understand the context of that for the child to know, does this represent pathology? Does this child actually need treatment? The last thing you want to do, of course, is to intervene inappropriately. So the ossification zones are the sutural zones. They're composed of zones of alteration. And there are isolated forms of synostosis, meaning it's just one suture involved. And then there are syndromic forms, and those are genetically driven. They're all autosomal dominant for the most part, and we'll look at what those look at. The isolated forms are not genetically driven, meaning there are genes responsible for them, and we'll talk about them, and we're doing some really interesting research about that right now, but they're not heritable. So we don't see it passed down from family member to family member, but yes, there are genes that are responsible for synostosis. The syndromic forms are absolutely heritable, and they result in multi-suture involvement. Typical incidence is 1 in 2,500 births. All right, so what do these look like? What are the forms of compensation? So we'll go around this wheel quickly, and then we're going to take them each individually. All right, so normal is in the middle here, and we just went over the sutural anatomy, so we're all comfortable with that. So let's start here at 1 o'clock. This is sagittal synostosis or scaphocephaly. So you're missing the sagittal suture. They also didn't draw on the metopic. It's because it closes so early. It's often closed in these kids. So you're missing your sagittal suture here. That means that the skull cannot grow perpendicular to the fused suture. Does that make sense, right? So usually, if you have an opening in the bones that allows for growth perpendicular to that linear opening. So if you're missing the ability to grow perpendicular to that opening, it will cause compensation along the axis of the suture. So because you're missing your sagittal suture, the brain can't grow and the skull can't grow in this direction, which we call the biparietal direction, which narrows the skull. It holds it in a narrow position. And then the brain is looking for room to grow. And so it uses the sutures it has. And so it's going to use the coronal sutures. And you'll get frontal bossing because the brain's going to push those forward. And you're going to use the lambdoid sutures, pushing the occiput backwards. And so that gives you that resultant elongated, boat-shaped, scaphocephalic skull. If you're missing your metopic suture, the frontal bones can't grow perpendicular to the metopic suture. So of course it's going to narrow the forehead because it's stuck centered around this bone. And it's going to use everything else it has for brain growth. So your coronal sutures are available. So the brain's going to push backwards more. You have your sagittal suture, so it's going to push out more. So you end up with a triangular shaped head because you're narrowed at the front where you're stuck. And the compensation is occipital bossing in trigonocephaly. So when we're talking about compensation in synostosis, we mean the resultant head shape because the brain is compensating for the area where it can't grow. All right, if you have both coronal sutures fused, you end up with brachycephaly, flatness along the back of the head and foreshortening of the skull because, again, can't grow perpendicular to these sutures. So your skull is stuck in a very narrow, in a different dimension, right? AP dimension, AP, so an AP limitation, and you get brachycephaly. Unicoronal is one of the most difficult to diagnose and distinguish from plagiocephaly. So here's plagiocephaly, and here's coronal synostosis. So in this image, you're missing the left coronal suture. So the skull is stuck around this fulcrum, meaning can't grow perpendicularly. So your forehead is flat, and here's the difference. The back of the head is also flat on that side. Your ear is pulled forward towards the ridged missing suture, the missing fused, I shouldn't say, the fused suture, and then the eye will also be elevated. I'll show you an example of that because you can't see this in this view. So everything's pulled towards this fulcrum. Here's the difference here. Here, if you have a plagiocephalic skull, Yes, your ear is pushed forward. Yes, it's pushed forward on the side that the back of the head is flat, but here's the difference. The forehead will also be pushed forward because there are no forces holding these bones in any position. They're being pushed from the back, and that vector is allowed to push all the way through the skull, giving you flattening here, the skull base, pushing the ear forward, and then the skull in the front. So your vector is carried all the way through to the front. With coronal synostosis, that's not what's happening, right? You have an internal pulling, you have a stuck fulcrum. So your forehead will be pulled back towards the ear on the side that you're flat. So it's subtle and you get good at it over time. But again, this is why this is all physical exam. Lambdoid synostosis is the most uncommon of them all. You don't need to know it, typically in practice. I'll show you some examples of it. All right, so that's just walking around the wheel of how to diagnose this. So how do we walk through diagnosis? So you use an algorithm because this is your most important tool. And you use the same approach with every child. So physical exam, again, the biggest part of this circle in terms of how to diagnose these children. So how do we approach physical exam? You look at cranial morphology and you start first with looking for symmetry. All right, so you look from the top down at the skull, the view I just gave you. You're looking for areas of asymmetry on the vault. You're looking for areas of asymmetry in the orbits. You're looking for areas of asymmetry in the ears. And if you do that the same way every time and you use that algorithm, you will not miss this. So you're looking from the top down, front on, and from the side, and you're going through the rubric I just showed you. Look at the vault, look at the eyes, look at the ears. And if you go through that every time, you will not miss it. Then you feel the sutures and you feel for ridging. Any suture that is fused is ridged. You have to learn how to distinguish that from overriding, as we just discussed during the birthing process. There's a lot of overriding. Really, the name of the game here is if you have more than one suture ridged and you don't have any compensation, as we just discussed, they're just overriding. That kid just needs some time. They need to gain some weight. Their brain needs to get bigger and they need to push those sutures back into alignment. And then compensation, as we just discussed. Anthropometry. So one other thing we can do is use cephalic index. So we use what's called a caliper. It's a little metal device that measures the biparietal diameter and the frontal occipital diameter. You divide those two and multiply by 100 and you get a number called the cephalic index. Okay, and that number, if it's in 75 to 85 range-ish, is normal for metastacephaly. If it is less than 75, you're in a dolichocephalic or a scaphocephalic range, meaning you're worried about sagittal synostosis. If you're greater than 83 or 85, I don't use 83, I use 85, but then you're in a brachycephalic range, which tips you off that you might be dealing with coronal synostosis. Now, this is just one piece. You would never, ever hang your hat on a diagnosis based on just a cephalic index. It's just another piece. And then if you're still confused, then you can reach for plain films or a CT. But honestly, if you can't tell from physical exam, it's not fused. So I really very rarely use these modalities. All right. So a child presents to you at 1 month of age for a weight check, was born full term, born via vaginal delivery, no complications. And the parents express a concern about head shape that has existed since delivery. That's a big difference from plagiocephaly, which usually is not present immediately after birth and develops over time because, again, it's an outward in phenomenon, not intrinsic to the bone. On exam, you note that the anterior fontanelle is small. There's a bony metopic prominence. There's some hypotelorism. Again, we're looking at the skull. So the skull told us that there was a bony prominence in the front. The fontanelle is small. Then we moved to the eyes and we found that they were too close together, meaning they're hypotelluric. The head circumference is tracking okay, but mom notes that he was born with this pointiness and it's getting worse instead of better, different from plagiocephaly. And this is the child's exam. So this is a classic trigonocephalic head looking from the top down. If you felt this here, you'd feel a ridge. If you look at this child from the front on, which I'll show you in a minute, the eyes would be too close together. And that's metopic synostosis. So here's a more severe form of it, just to drive the point home. Severe metopic ridging, restriction of the frontal bones, compensatory bossing of the occipital bones, and the eyes being held too close together, hypotelluric. So calvarium, oculi, oculi, and then the auriculi in a metopic will be fairly normal. So in terms of the treatment, there is an option for endoscopic sutrectomy with helmeting after, which I'm going to show you what that looks like, or anterior cranial vault remodeling with orbital distraction. I'll show you what that looks like as well. What this means is the difference between a small little linear incision behind the hairline and endoscopic removal of bone, or a zigzag bicoronal incision with complete orbital and frontal remodeling. The difference here is the age that the patient presents. If children present under the age of 4 months, you use endoscopy. If they present older than 4 months, you use an open cranial vault. And I'll show you what both of those modalities look like. This is just to show you what this looks like if you do get a CT. So at a child, a 1-month-old child should have nice big openings in the metopic region. This is the anterior fontanellar soft spot. These are the coronal sutures. This is what it looks like when the metopic suture has closed too soon. You still have your coronal sutures, but the soft spot is a bit small for age. The eyes are held way too close together or hypotelluric compared to this child, and the frontal region is restricted. All right, next case is a 5-week-old baby here because mom was concerned about her eyes. She feels that they are asymmetric. She was born a little bit post-term, a little bit large after an extended labor, and she had a cone head at birth, but that improved over time, and yet the orbits aren't getting better. And this is really common. You have to be able to sort out what's normal pathology after delivery and what represents potential surgical pathology. So a child that is born post-dates, a bit large for gestational age, with an extended labor is always going to have a whole bunch of abnormality and asymmetry. They'll probably have a cephalohematoma, which is this cone shaping of their head. All of that should just settle itself out and get better over 4 to 6 weeks. Then if you're left with residual asymmetry and concern, that's when you have to go back to the drawing board and sort out whether or not there's something else going on here. This is what this child looks like. The mom was spot on. So this orbit is higher than this one. So the right eye is elevated, the left eye is depressed. And if you look at her from the top down, hold on, I gotta move my window. You're seeing that she has retrusion of the frontal bone here and bossing of the frontal bone here on the side that she is elevated and bossing on the side that she is pushed down. So that is described as coronal synostosis. All right, so a couple more examples just to drive this home. Here's a really good example of it. So this is elevation of the orbital rim, depression of the contralateral rim. Again, this is just the brain looking for space because it's compressed and restricted in growth here. So the brain is looking for space. So it's bossing the frontal bone on this side and pushing this orbital rim down. This child is actually post-op from her endoscopic sutrectomy. You can see her steri-strips here. And I'll show you what that surgery looks like. And then we removed the coronal suture here. So again, normal would look like this. Nice big openings. Here's coronal synostosis. No opening here where the coronal suture should be. Some limitation of the anterior fontanelle. And again, the bone's just completely stuck around this fulcrum and compensating everywhere else. Here's another example, front on and top down. Same surgical options here. Anterior cranial vault remodeling versus endoscopic assisted sutrectomy. Now, you have to take into consideration not just age with coronal synostosis, but how bad is their orbital asymmetry when they present. And we'll go over why when I show you what the surgical approach is, but an open cranial vault correction for this involves remodeling of the frontal bones, but also removing the orbital rim and remodeling the orbital rim so that you can pull this orbital bone forward, push this orbital bone backwards, and then also fix the vertical dystopia. Okay, so that's, you have to take into consideration, do you think that this child is going to be able to achieve a substantial enough correction with just an endoscopic release based on their morphology and severity when they present? There's a lot that goes into that. I'll go over some of that when we're looking at the surgery, but it depends on a lot of factors. Is this child large for age? Is their bone thick for age? If they're small for age and their bone is thin, they're going to respond really well to an endoscopic release because their bones are thinner and their brain is going to be able to remodel that very quickly. If they're big for age and their bone is thicker, they're not going to respond as well. So even if they're technically in the right age range, you have to think a little bit about your surgical outcome. And even if it means recommending a larger approach via the open FOA and cranial vault remodeling, sometimes that's what's best for that child. And I'll show you why when we look at the technique. This is what these kiddos can look like at birth. This was a kiddo of mine all the way through to 2 years of age. So this is the severity of her deformity at presentation when she was about 1.5 months old. This is her after her release with her helmet on, already significantly corrected, but still a little elevation here. And if I took her helmet off, you'd see a subtle amount of protrusion. But this is releases her at 2 with really good correction. So again, understanding that it's the physical forces of the brain growth pushing the skull into a better position that is what achieves the correction for these children. So all we're doing in our procedure is just removing the abnormal bone, removing that restriction in physical force as the brain is growing, and allowing the brain to do its job and pushing the skull and the orbital rims into a more normal position. So we do the release, and then over time, brain growth gets you to here. All right, this is sagittal synostosis. We already went over the nomenclature. This is just to give you yet another more severe example. Frontal bossing, vertex slanting with the sagittal ridge, if you were to palpate this child's head here, and occipital bulging in the back. Again, the treatment options being cranial vault remodeling or endoscopic assisted sutrectomy with helmeting after. Lambdoid synostosis, the last entity, the hardest to diagnose and the most rare. This child's lambdoid synostosis is on the left. I know it's confusing because the CT over here is different. But so this child is fused on the left. The ear and the mastoid process are always pulled down and back towards your fusion. And there's a windswept appearance of the skull up and forward on the other side as the brain compensates and tries to grow away from that fused suture. So you always see this windswept appearance up and away from the fused suture. It's also really hard to tell sometimes if this is plagio or not. So there's this nice schematic of how to tell the difference. The left-sided schematic is a parallelogram, and that's plagio. Right, so the back of the head and the forehead move forward along the same vector in plagio. With lambdoid synostosis, you get a trapezoid. So the side that you're fused on, you're also restricting the forehead because again, this whole side cannot grow perpendicular to the fused suture, and the brain is looking for compensatory growth to the other side. All right, so trapezoid versus parallelogram, looking from the top down. Again, you're getting the sense that that bird's eye view is your clincher in terms of physical exam with synostosis. All right, and lastly, syndromic synostosis. Very important to know these for any boards exams, but much more rare unless you're in my line of work in which this is all I see and do. So craniofacial surgery, this is the complex patient population that we treat. So syndromic forms of synostosis really don't exist in isolation. All right, so you're not going to miss these kids. These kids do not have only calvarial or midfacial restriction. They have digital abnormalities, systemic abnormalities, usually cardiac and renal, and you need a team to care for these patients. They are all autosomal dominant, and the most common genetically associated genes are FGFR1 and 2, in addition to twist. And those are really the 3 that are typically associated, but Pfeiffer's, Aperts, and Cruzons are all FGFR. It's important to know, to treat these children well, the team that you need is about 8 subspecialties. So we have a craniofacial clinic, a multidisciplinary clinic. I am part of it both here and at Columbia. Our space at Cornell is over in the ENT clinic. We meet once a month together for anyone who's interested. I've had several students rotate with us there. The team includes neurosurgery, plastic surgery, ENT, OMFS, dental surgery, orthodontics, sleep medicine, pulmonology, speech therapy, child life, and social work. And actually last week we included an oculoplastic surgeon. So it's a really massive team, but that's what these children need, because yes, we're focusing for the purposes of this talk on how you fix the calvarial and midface deficits, but the restriction of growth impacts so much because they then have tonsillar ectopia, herniation, and brainstem compression. Their midface involvement, so it's not just the calvarial sutures we were just speaking about. These children, as you can see here, have restriction of their midface growth, which is what causes this beaking of the nose. They're restricted in their frontonasal suture, their maxillary bones and all sutures behind them, frontomaxillary junctions and all of their skull base sutures, those little teeny tiny junctions on CT that we were looking at before, all of those are restricted. So yes, they have typically coronal synostosis, but also mid-face hypoplasia. And so that restriction leads to difficulty with airway obstruction. Almost all of them are trached in PEG because they're not allowed to, they're not able to, their airways are obstructed as well as their oropharynx. So their entirety of oromotor function and control and airway passages are blocked. So trach and PEG is standard for these children. And then the surgical correction that they need spans immediate to gain control of hydrocephalus because they're usually obstructing at the foramen magnum from tonsillar descent and ectopia and secondary Chiari because their their growth is restricted. So we have to place shunts immediately. Then we have to do a cranial vault remodeling, which I'm going to show you to give them more room. Then we have to wait for them to gain skeletal maturity to advance and bipartition all of the facial, the mid-face fusions. So we essentially have to approach this. I'll show you the surgeries in just a moment, but from a top-down approach. So you treat the pressure, you put in a shunt, then you do the fronto orbital advancement. So you give them more room and address orbital structure because all of them have what we call proptosis. So there's not enough room for their orbits. So their orbital fossae are too shallow. And their orbits are usually exposed. Sometimes one of the last children that I treated, she had exorbitism. She was showing up in the ED every month to have her eyes popped back into her skull because there was just not enough bone to even house her orbits. And so her optic nerves and her vision were at risk because her eyes would literally fall out of their sockets. And so all of this shallowness affects their function. So we address that first. So we give them enough room, we protect their brain pressure, and then we protect their orbits at a very young age with a fronto-orbital advancement. But the rest of their midface is still restricted, requiring assistance with breathing and feeding. So when they gain skeletal maturity, we then go back, we disconnect the entire face and jaw from the skull base down, called a Lefort 3 procedure, and advance it forward to correct for the compensation that has happened from the mid-face restriction. So it's a stage series of 3 to 4 surgeries over the course of their lifetime that ultimately results in correction. Again, that in and of itself is really a completely other talk. I'm happy to go through all of that, but those techniques are very separate from what I do on my own, and we do those as a team. But I'm today going to go over the endoscopic, sutrectomy, and frontal orbital advancement because that's what I do from a neurosurgical standpoint. So just looking at these syndromes in a little bit more depth so that you know what they entail. Apert syndrome presents with turibrachycephaly from bicoronal synostosis, midface hypoplasia from midface sutural fusion. You see parrot beaking in those kiddos. This is an example on a sagittal view of parrot beaking because of mid-face hypoplasia. The entirety of the maxillary anatomy, jaw anatomy, it's all rotated and pulled back. So she can't even close her mouth appropriately because of that mid-face hypoplasia. And you're seeing here the compensation for it. So the coronal sutures are fused. The brain is looking for room, so it widens the sagittal suture, drastically widening or diastasing the skull base sutures. Look at this. It's just the brain is looking for room to grow because the midface and the coronals are all stuck. So that's why, again, you have to address the pressure issues. You typically have to provide CSF diversion. Then you give them enough room by taking off the frontal bones and the orbital rims. Then you address the midface and the jaw. So top-down stage surgical approaches, FOA, Lefort 3, and then the last thing that's done is OMFS rotates the jaw up. They also have syndactyly, so examples of syndactyly here, and developmental delay. Cruzon syndrome also has brachycephaly, midface hypoplasia, and the exorbitism that I was describing. So here's an example of exorbitism. Again, the orbital fossae are too shallow because of the fusion of the sutures and the midface hypoplasia. So these eyes are essentially not even sitting in the skull. You can see how far out they are. They're just sitting in the soft tissue. The difference between aperts and cruzons, typically, there is also, they more commonly present with hydrocephalus. They more commonly present with Chiari malformations, again, because of the crowding at the skull base requiring CSF diversion more commonly than aperts, and they have a conductive hearing loss. Pfeiffer's, also turbobrachycephaly, also midface hypoplasia. This is consistent across all three of these always. Exorbitism, a little bit more common. They have these broad thumbs and great toes. So this is a Pfeiffer's with these broadened and abnormal great toes and thumbs and variable syndactyly. So sometimes they will present with syndactyly, but much more commonly in the aperts and the cruzons. So, these syndromes are not subtle. You will not miss them. They are multifactorial and they require a multidisciplinary approach in the treatment. In our practice, since we came together as a team, Dr. Maharobo and I, here in 2014, and started treating multidisciplinary patients. This is what our surgical volume has done. And let's look at what the surgeries are. So, endoscopic sutrectomy. This is a modality and a technique that has evolved predominantly over the last decade. It now serves as bread and butter standard of care for children that present under 4 months of age with a single suture synostosis. This is not typically standard of care for any syndromic form of synostosis, even isolated bicoronal. So there are children that can present with bicoronal synostosis in the absence of a syndrome. And I typically will not treat those endoscopically. You will find some literature on endoscopic treatment of bicoronal synostosis. I think we need a lot more evidence that that's the appropriate treatment before I start using it universally. So of course this developed because it's much more minimally invasive than the procedure I'm going to show you next, which is the standard frontal orbital advancement or open cranial vault remodeling. It simplifies the perioperative process as well, in that it is a much shorter procedure. This takes us about an hour versus 8 hours. So you don't need to place a Foley catheter and therefore decrease the risk of UTIs. You don't need to place an A-line because it's very rare that these children need transfusions. Again, the procedural time is much decreased. Our rate of transfusions is about 7% in these children versus essentially 100% in a vault. And these children go home the next day. Now, our vaults don't stay terribly long either. Children do really well, so they're only staying 2 or 3 days. But again, home the next morning is nicer for parents than staying 2 or 3 days. One of the differences here is that these children need orthotic helmeting for about 6 to 8 months after. The difference being, when we're doing a cranial vault remodeling, which I'll show you, we're doing all of the work for that child on the table. So we are advancing their frontal bones, we are advancing their orbital rim, giving them symmetry back, and doing all of the work that they need in terms of cosmetic and functional improvement on the table. With endoscopic suturectomy, all you're doing on the table is removing the abnormal physical forces and giving that child's brain a chance to then continue on normally. So the brain still has to remodel the bone, and there's all of this existing compensation that's already gone on that we reviewed, meaning they've already elongated their head in sagittal synostosis, they've already developed trigonocephaly and metopic, and they've already started to lift their orbital rim and flatten their frontal bone in coronal synostosis. So you need to help shove that process along a little bit because you're not doing that on table. So those children need orthotic helmeting afterward to help that corrective process. The infrastructure for endoscopic suturectomy is different from open. Again, you need the endoscope, you need the tower. This is an endobrow sheath that we utilize with a 30-degree scope. It's very specific and very different from any other endoscope that we use. You need insulated retractors because you're going to be using cautery on the dura. You need suction cautery to provide hemostasis along the bone edges. I'm going to show you videos of these in a sec. You'll see all this in action. I don't use this anymore, so we won't discuss that. This is a Doro head frame, which holds children in the Sphinx position, which I'll show you. And this is a really cool tool that's developed over the last few years, and we just published on our use of it. This is the sonopet. This removes bone and hemostasis at the same time through ultrasonic aspiration instead of a drill, and allows you therefore to get into really small spaces and do this procedure with much less bone removal, much faster, and much less blood loss. It's a really nice tool that we now use and have kind of really pushed forward the utilization of this in endoscopic sutrectomy. These are Tessier scissors. Infants under the age of 4 months, you can literally cut through their bone. That's why this is an appropriate approach for young children. And this is a gooseneck rongeur. So we're doing these procedures, which I'm going to show you in a minute, through really small access points. So you need instruments that can get into that little access point, but then reach really far along the axis of what the endoscope is able to visualize. So bone is a really hard surface. It's very difficult to work with bone that is, you know, down a 12-inch, just 12-centimeter corridor far away from you. So you need tools that can protect the dura, keep the patient safe, and also that help you to remove bone that far away from you. And so these are the tools that allow you to achieve that. And then, of course, you need your plastic surgeon. There's my partner, Dr. I. All right, so what does this look like? The objectives of endoscopic sutrectomy are, of course, achieving a cosmetically silent skin incision. So I'll show you where we place that. You then perform subgaleal dissection, meaning between the galea and the bone. You then have to create an access point to remove the bones. You have to create burr holes. You have to perform an epidural dissection, meaning your dissection between the dura and the bones, so that you know that your bony removal is safe. You then have to perform the suturectomy. You have to take out the pathologic bone. You have to create hemostasis, meaning stopping blood loss, and you have to close. So how do we do this? Here's a sagittal sutrectomy. All right, so this is that Doro head frame that holds children in what we call the Sphinx position, because the suture we need to operate on is at the top of the head, so we can't have a patient laying on their back, because the surgical anatomy is on the top of the head. So this is the Sphinx position. You pad the child with gel rolls underneath. You try to prevent overextension, and then you have access to the vertex of the head. So where are the incisions placed and what does it look like? We'll walk our way through metopic synostosis, sagittal synostosis, and coronal. So, metopic synostosis. You place your incision behind the hairline so it's cosmetically silent. You remove the strip of bone that's shaded out here with your endoscope, your drill, your Tessier scissors, and your sonopet. And this is what it looks like. So there's your incision behind the hairline so you never see it. Once you make your incision, you make a little burr hole so you have an access point to the dura. You're looking at the pulsation of the brain there with the dura. That patty is being placed in the epidural plane. That's your epidural dissection right over sagittal sinus to make sure that your bony removal is safe. This is monopolar cautery through pericranium, ensuring that you're reducing blood loss. You're not inadvertently taking bites of galea. And then you start your bony removal. That's that gooseneck rongeur, removing the fused metopic suture. Again, you're working over the sagittal sinus, so you need to be extraordinarily careful that you don't create a dural tear. That's bone wax, creating hemostasis as you go. Again, trying to decrease transfusion rate. That's the use of that insulated retractor and suction cautery that I was describing. Down in that left corner is what it looks like outside the patient with the endoscope in the small incision. This is the sonopet in action. So it ultrasonically aspirates bone and hemostasis at the same time, and it's only a couple millimeters. So this view looks huge, but the endoscope is only 9 millimeters. So you have to realize what you're looking at is really only about a centimeter in width. And so we're able to remove bone without any bleeding. And get down into really narrow spaces with this tool. And it's wonderful for getting us all the way down to that frontonasal junction where the metopic suture ends. If you don't take out the entire fused suture, you might as well have done nothing. Because if you still leave a fusion point right here in between this child's eyes that is being held too close together, holding the frontal bone too close together, you might as well have done nothing because you haven't served that child properly. So you have to get all the way down to the frontonasal junction through a tiny little 2-centimeter access point very far away from your end goal. All right? Okay, that's that frontonasal suture. So you have to get all the way down to the junction between the frontal bone and the nose, and you're seeing right there the beginnings of the nasal bone and the septum so that you know that you've hit your target. All right, what does sagittal endoscopic suturectomy look like? So this is different. We have to remove this bone here. So you have to choose an access point that allows you to, with an endoscope, see all the way forward to anterior fontanelle, or here all the way forward to anterior fontanelle, and all the way back to posterior fontanelle. Right? So your sagittal suture runs between anterior fontanelle and posterior fontanelle. So you have to get all this bone out through one incision using just an endoscope. So the way that we place the incision, which is a single linear incision between the two, is based on the contour of each individual patient's skull. So the endoscope is a linear, rigid instrument, right? So going around corners with it is going to be very, very difficult. So you want to limit how much corner you have to look around with an endoscope. So that's why I always place it a little closer to the posterior fontanelle than the anterior fontanelle, because this vector is actually pretty straight shot with the endoscope, not that hard, even though it's farther. If you were to place it here and you had to look all the way around this corner down to posterior fontanelle, you're not gonna be able to do that very easily. The skin's gonna limit you. So you put a linear incision there. This is what this looks like. So again, you're positioning this child differently in the Sphinx position, not in their back. That's where the incision is placed. This is the endoscopic view. So again, same principle. So you've made a burr hole through that incision. You're using your gooseneck to start the bony removal before getting your sonopet in there when you can no longer reach far enough. You're protecting sagittal sinus right under you because again, all of this is in the midline. So every time we're working right over sagittal sinus. That's what it looks like bottom right in terms of working through this little incision and looking up at the monitor. There's the rongeur gooseneck that I was just describing, taking those bony bites, right? Fast forward here. There's the use of the suction cautery on the bone edges, again, protecting the dura with your insulated retractor. Okay. Hemostasis with some gel foam and closure. All right, lastly, coronal synostosis. So very different deformity. Again, now our suture starts at the anterior fontanelle, but it ends down here at the squamosal suture. So you have to get from here to here where it comes into the lateral orbital rim with just your endoscope. So in this case, the incision is placed linearly behind the coronal suture in the hairline. Oops, I'm sorry. Okay, making a small linear incision. Opening that incision with monopolar cautery. Each of these just gives you a little bit different view because you don't need to repetitively go back over it. This is that subgaleal dissection that I was describing. So your first task is separating galea from underlying pericranium and bone carefully. Your wound healing is going to depend on maintaining the integrity of the galea. Then you make your burr holes. So this wasn't incorporated in the other videos because it's in this one. So this is your bony access. Okay, so burr hole. Now you're down to dura. And then you start the process that you were seeing utilized in all the other ones. Now this is a nice view of dissecting the galea off of the fused suture. So you can probably appreciate, see that ridge? So that's seeing that fusion in situ. So that's the coronal suture. This should be a nice flat interdigitated bone, and instead you're looking at this ridge, okay? Now this is the use of the sonopet alone going through bone at the farthest reaches of the coronal suture. It's a really nice tool. This is the claw tip, which is what we published on actually, because the back of it is blunt and doesn't damage tissue, and the other end goes through bone. So you can safely protect either dura or pericranium and remove. So there you go, that's it, suture's gone. So that was the use of a technique to use that sonopet to create your bony opening at that distal end that's really hard to access manually, and then performing those last few bites with your gooseneck. And then the same process that you've already seen, hemostasis with your suction cautery. All right. This is just our recent publication on the use of the sonopet for that technique. And then we put them in helmets. That's what their orthotic helmets look like, and they correct. So if a child presents older than 4 months of age, then you have a couple of options at your disposal. The first is if it's sagittal synostosis. If they're between 4 and 6 months of age, you don't have to do a full cranial vault remodeling. You can do what's called an extended vertex craniectomy. It depends on the institution you train at. Not everyone utilizes this technique. NYU does and Sick Kids does, so I was trained in this technique and I use it. It involves just I use an S-shaped curvilinear. Some people use a linear. I don't like this because it doesn't get you as lateral access as this does. So whenever you're deciding on a surgical incision, your access point will be from the most lateral aspects of the curvature of your incision. So this just gives you a little bit better lateral exposure. You then, once you have your skin open, take out under direct visualization instead of the endoscopic view I just showed you, your sagittal suture, and then you do what's called barrel stave osteotomies, where you create lateral cuts in the bone down to where you meet the squamosal suture here, which allows for correction of that biparietal restriction that we saw when we were talking about the pathology and the resultant head shape and compensation. So that's called an extended vertex craniectomy. It's suitable for children 4 to 6 months before you have to move to a complete cranial vault remodeling. This is what it looks like in situ. You take off that sagittal strip of bone, you do these barrel staves laterally, and then you replate all this bone with resorbable plates and screws. It's called the Delta system. It's made by Stryker. Now, if children present after 6 months of age or in the 4 to 8 month range, or as we discussed, they have severe enough pathology that you just don't think they're going to get good enough correction through the endoscopic approach, or lastly, as discussed previously, their bone is too thick, their constitutional growth is rapid for their age, you're going to need to reach for just a frontal orbital advancement. So we hold a practical course every year where we go through these approaches, both endoscopic and open, in the lab. A medical student created these amazing models that are created off of 3D printed models from our patients. And they allow you to understand and appreciate the sutural anatomy and go through the steps in real time on your own, do the plating, do the drilling, understand how to use the sonopet, and we hold this once a year for anyone that's interested. A lot of students participate every year. It's an internationally attended course. At our course last year, we actually decided to document all the steps one at a time, which is great because it gives you a view you just can't gain in the OR as we walk through these steps too quickly. In the OR, you really get beginning and the end. You don't get anything in between. So I included our pro sections from that to give you a sense of what a frontal orbital advancement entails. So we use FOA for all 3 entities. You just have to do different things to fix the compensation, meaning we use it for sagittal, metopic, and coronal. We just have a different goal in terms of what are we fixing. You know, do the orbits have to be moved farther apart in a metopic? For coronal, they have to be elevated and lined up. For sagittal, you're really just fixing the bossing and the restriction that's occurred. For all of them, you use a zigzag bicoronal incision that looks like this, and therefore you can see that that gives you access to the entirety of the calvarium. This patient was a sagittal synostosis. You then make your cranial vault markings to plan your osteotomies. So Dr. I uses methylene blue, and he does just this in the OR, and he draws on the skull for me, and he shows me exactly the bone that he needs removed to achieve the cosmetic and functional result that we need to give that child enough room for brain growth and to advance the orbital rim. So he's showing me here are going to be my burr holes. I'm going to use the anterior fontanelle for my bone openings anteriorly, and then this is my sagittal sutrectomy. This is where he wants the barrel staves to reach. We take it off, we perform the barrel staves. Now, part of the abnormality in a sagittal synostosis is that their vertex has become elevated over time because, again, they're restricted in a lateral dimension. So they look forward, they look upwards, they look backwards for growth. So not only do you have to make these osteotomies, but then you have to correct for all of that compensation. So we do what's called green stick fracturing, which means we use this bone bender that pops the bones out, but at this age, they won't actually fracture because the pericranium will still hold that bone in place. And so it's a green stick fracture because the bone is still held together, but you hear this little click and the pericranium holds it there. So it holds it in this out fractured position to correct for the biparietal restriction. And then we pull it down. So we green stick it down to pull the calvarium down and correct for that elevation in the cranial vault, right? So see a little green stick here, green stick here. We're pulling that down and correcting for that compensation. We then use, these are the same ones we use in the OR, absorbable plates and screws to plate across the sagittal suture, reposition it, pull the whole construct down and outward. And then you can see down here, The whole correction of compensation has been to widen the skull to correct for the biparietal restriction, to pull it down, and to advance a little forward. And then you have this resultant corrected calvarial shape. Very different surgical goal for a coronal synostosis. So we use the same incision, but the difference here is what we're trying to correct for is brachycephaly, totally opposite from scaphocephaly, right? This is a foreshortened skull. And the orbit is elevated on this side. Here's the fusion. It's elevated and pulled back. So in order to fix that, right, so looking top down a little bit, see how it's protruded here, it's elevated. We have to remove the entire frontal bone, remodel it to pull this forehead forward to meet this one and pull this one back a little because it's compensated too far forward. We have to take off the entire orbital bandeau, which means we have to come through the skull base at the zygomatico-frontal suture, the frontonasal suture. We have to come through the top of the orbital rim and remove this bandeau. And then Thomas takes it apart, repositions it so that then the orbital rim is in line, and then we replate it. So again, he's drawing his lines for me. This is what my craniotomy is going to look like. This is where I have to make my burr holes to take the bandeau off. And then we remove it. This is what it looks like from the top down, just so you can gain an appreciation for the pathology. And this is what it looks like when we're done with that part. And I'll show you what the reconstruction looks like. But so the frontal lobes are exposed by the frontal bone removal, and then all the way down to the nose and the tops of the eyes by taking off the frontal bandeau, the orbital bandeau. So this is the top of the nose. And this, if we were in situ, would be the actual orbits of the eyes, okay? Looking at it from the side, you're seeing the frontal lobes, you're seeing the temporal lobes. This is the lateral orbital rim, this is the eye. And all of that's exposed in the surgery. Top down, you're looking at the orbits, all exposed. So to come through and take this off appropriately, I have to protect the dura intracranially. Thomas has to protect the orbits extracranially. And then we come through with the sonopet and we make these cuts with protection on both sides. We green stick out to correct for some of the restricted growth and compensation. And then here's what these pieces look like that he has to work with. So this is what the frontal bone looks like. Again, see how it's flattened on this side and embossed on this side. This is what the orbital rim looks like after we remove it, and see how much it's all asymmetric and wonky. So he cuts it in half. He pulls them towards one another, right? So he pulls one back and one forward. He also will bring them together a little bit and lower the one that was elevated over time. He then takes the frontal bones and swaps them and creates cuts in them and rotates them so that they can accommodate for brain growth, pushing them into a better position, and also corrects for the existing compensation. And then we plate all of that just the way you saw the sagittal patient plated with those absorbable plates and screws, and reaffix it all and close it the way you saw on the sagittal. So, that's a very brief run through an extremely complex entity. Each one of these, to be honest, is its own 1-hour talk in and of itself. I hope that gives you a little bit of an overview and enough of a technical sense of, how we go about this and some of the surgical considerations. But invite any questions of anything I didn't touch upon that you guys are curious about. And also just to invite you to the OR, for anybody that's interested. I do usually at least one of these a week, sometimes 2 a week. And then of course we have clinic once a month for anyone who's interested.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.